Hi, this is Darcy Gaydon, and I am just recording audio for the endocrine system PowerPoint. So some of the A&P review for the endocrine system is very, very important. So this picture just depicts the different hormones and glands that we will be talking about. I want to point out at the very top, you'll see the hypothalamus. The hypothalamus is responsible for sending out the releasing and inhibiting hormones, and it controls what is released from the pituitary gland. So the hypothalamus communicates with the central nervous system and then sends its releasing or inhibiting messengers or hormones to the pituitary gland. Then the pituitary gland, which we also call the hypophysis, or our master gland, we have the anterior and posterior pituitary, basically send out the stimulating hormones that then send the messages to the gland itself. So for example, the thyroid stimulating hormone, once released by the anterior pituitary, will go to the thyroid gland and then tell the thyroid gland to produce more of that given hormone. A few things that I'd like to point out in this picture, if you look at the top, again, the hypothalamus and the pituitary gland both sit up in our brain area. And so I just want you to know or make the connection that if any patient has brain trauma, brain injury, accident, brain tumors, any head injuries, head traumas, all of those things are going to affect the endocrine system because they're going to affect the hypothalamus sending its message to the pituitary gland, and then the pituitary gland is sending its messages to the gland themselves. So again, the hypothalamus is the structure in the central nervous system that links, it's the link between the nervous system and the endocrine system. It controls the release of the pituitary hormones. The pituitary gland then, again, both anterior and posterior, will send messages to the other endocrine glands. You see the thyroid gland there, and then the 4 dots on that thyroid gland are our parathyroid glands. The adrenal glands that sit right on the top of both kidneys, we'll be talking about the adrenal glands. And then, of course, the islets of Langerhans in the pancreas. We're not going to be really discussing the reproductive organs and hormones in this unit, but we will be talking about all of the others. The feedback mechanism is very important in understanding how our hormone regulation works. Basically, this mechanism will basically produce an increase or a decrease in the level of the substance depending on what how much the organ is producing the substance. So for example, you'll see if we have a decreased calcium level, that stimulates the parathyroid gland to release parathyroid hormone. We know the function of the parathyroid hormone then is to promote kind of pulling that calcium from the bone and therefore increasing serum calcium. So that would be how our gland, how that feedback mechanism works in response to a low blood calcium. But it is no different than for other hormones such as insulin. High calcium will just be the opposite. So we'll be talking more about these things with each condition, but just want to make sure you're understanding that this feedback mechanism hopefully is functioning for people and then will regulate that hormone imbalance. This picture shows the hormone regulation then for calcium. And so again, we know that calcium is regulated by calcitonin and parathyroid hormone. So calcitonin keeps, that's a good way to remember it, or calcitonin tones the bone. So again, if we have a high blood calcium, calcitonin is going to keep more of it in the bone, tone the bone, and build up more of that calcium in the bone, which will then decrease the blood calcium level. And we just talked about the opposite of the low blood calcium level. So again, this is just another example of the feedback mechanism. The endocrine assessment in health history is quite different than other body systems because we don't have a lot of physical assessments per se, or lung sounds or heart sounds, but there's such a wide variety of symptoms with the endocrine disorders that we'll be talking about, but many of them you'll see here: change in energy level, heat or cold intolerance, changes in weight, changes in sexual function, mood, memory, sleep, the eyes protruding, the exophthalmos that we see with hyperthyroidism. So again, many of these go with thyroid gland disorders because the thyroid gland regulates our metabolism. So if we have slowed metabolism, we're going to be more tired, we're going to gain weight, and different things like that. We'll talk about the steroid side effects, or Cushing syndrome, which you see in that bottom bullet: moon face, buffalo hump, thinning of the skin, truncal obesity. Those are all side effects of being on steroids, and or would be the signs and symptoms of excess of cortisol, which we see with Cushing syndrome. So again, we'll be talking about each of these, how they directly relate to different disorders, but you can see hopefully some of the types of questions that we might ask our patients if we are thinking that they have an endocrine problem. Endocrine system age-related changes are listed here. We know that as we age, we will have decreased glucose tolerance, so there's that chance of insulin resistance developing. We know that there's a higher rate of development of type 2 diabetes with that insulin resistance, especially with obesity and inactivity, etc. Decreased metabolism, of course, there is a slowing of metabolism no matter how active or healthy a person is. That is just naturally going to happen with age. So weight can, become greater than ideal, even with the same amount of food intake or exercise, just because of the decrease in BMR. Some other hormonal, decrease in ADH, more risk of dehydration, decrease in estrogen production as far as the bone density problems and osteoporosis. So again, we'll talk specifically of different things, age-related things that can come up with each of the individual disorders, but this is just an overview to get you started. Diagnostic evaluation for the endocrine system, again, varies pretty significantly also. We do have several blood tests that are helpful, especially the thyroid stimulating hormone, which will, with 99% accuracy, diagnose thyroid conditions such as hypo or hyperthyroidism. The T3 and T4 are the actual thyroid hormones, so they can measure those directly. However, you'll see more commonly the measurement of the thyroid stimulating hormone. Parathyroid hormone and calcium. Of course, we can look at the glucose levels, which are very important as well. Some of these other tests, radioimmunoassay, the 24-hour urines, and stimulation and suppression tests, those aren't really necessarily ordered in an acute care setting. Unless somebody's really doctoring for some major endocrine problems, and they're probably going to be in a higher level of care if you're working there. But the 24-hour urine, just going to review. Everybody remembers how to do that. Of course, we're going to start the clock. We're going to have the patient void. We're going to discard that first urine. And then we're going to keep all of the urine samples for the full 24 hours. It depends on whether or not they have we'll keep them on ice unless they have, oh gosh, why am I having a blank here? But if they have the preservative, it doesn't need to stay on ice. But either way, we will make sure we don't miss any voids. And then once the 24 hours is close to coming up, within, like 10 minutes of that time, we'll have the patient void again and try to get that final void that we also do add to the collection. As far as the stimulation and suppression test, this is basically where we are going to administer a stimulating hormone, a synthetic one that would mimic that, or suppress the hormone to see how the body responds. So basically this is testing if that negative feedback mechanism is working, because we have to find out if it's an actual hormone problem or more of a gland problem in what it's producing, again, that if that negative feedback mechanism is not working. So this is another quick picture just to review the ANP. We have the hypothalamus at the top that's going to has the thyroid releasing hormone. Again, remember the hypothalamus sends the releasing hormones to the pituitary gland. Then the pituitary gland is going to send the stimulating hormone, in this case the thyroid stimulating hormone, to the thyroid gland. That stimulating hormone then is going to tell the thyroid to make thyroxine, to basically make the T3 and T3 hormone. So if there isn't enough, for example, if you have a low amount of T3 and T4, that's going to send a message back to the anterior pituitary. You see that letter B. So if we have a low T3 and T4, it's going to send a message back to B to basically increase the thyroid stimulating hormone so that it can tell the thyroid to make more. So that's how the feedback mechanism will look. That is also why there is always going to be an inverse relationship between T3, T4, and TSH. So if T3 and T4 is low, the thyroid stimulating hormone would be high, and that should make sense because if we have a decreased amount of hormone, we need more stimulating hormone to send messages to the thyroid gland to make more. So disorders of the posterior pituitary gland, we'll be talking about hyposecretion and hypersecretion of ADH. ADH is our anti-diuretic hormone. Remember, ADH is our water-conserving hormone. So hyposecretion, or a decreased amount of ADH, we know that disease to be diabetes insipidus. Increase in ADH, we know that to be syndrome of inappropriate anti-diuretic hormone. So you can remember hyposecretion or decreased ADH. So we have decreased water conserving hormone. If we have decreased water conserving hormone, we think of not holding on to enough water, and the patient can get very dehydrated. So death by dehydration is another way that you can think of diabetes insipidus. So again, decreased water conserving hormone, cannot hold on to enough water, therefore there'll be large amounts of increased urine output, large amounts, liters and liters of very dilute urine are voided, and so death by dehydration. Hypersecretion, so think of increased water conserving hormone. Well, if we have increased water conserving hormone, we are going to have fluid volume excess, right? We're holding on to water, and therefore you'll notice the decreased urine output there. Again, remember there's always going to be an inverse relationship also between urine output and specific gravity. So for example, with diabetes insipidus, where they have an increased urine output, they're putting out liters of fluid, we would expect that urine to be dilute, right? So that would be a low specific gravity number. Remember, specific gravity is 1.010 to 1.030, and so we would expect that number to be low, less than 1.010 for diabetes insipidus. Again, just think about it logically. Increased amount of urine is going to be more dilute. So the value of the specific gravity is going to be down. This diagram is showing the feedback mechanism for antidiuretic hormone. So on the left you can see hemoconcentration. Remember, that's the same as increased serum osmolality, right? The concentration of particles relative to volume. So hemoconcentration, high osmolality, is going to occur when there's a hypovolemia or a low blood volume, right? Less volume will make the particles more concentrated. So when there's hypovolemia or high osmolality, that's going to activate the release of water conserving hormone, right? We have low volume, low water, and a high concentration, so our body signals that those receptors in the posterior pituitary to release more antidiuretic hormone. So then you'll see that the kidneys become more permeable to water, and water is conserved. So we're retaining water in hopes to increase the blood circulating volume and therefore lower that serum osmolality. Negative feedback on the opposite side, hemodilution. So if we have hypervolemia, we have more volume, and we would have a low concentration of our solutes or a low osmolality. So all of those particles are diluted down in that large amount of volume. So that's why we call it hemodilution. That's going to stimulate the posterior pituitary to decrease the amount of water conserving hormone because it already knows that it has enough water. So water will not be reabsorbed and diuresis will occur, and hopes to of course, to change that concentration and lower the amount of volume that we have. So here's our slide on diabetes insipidus as far as signs and symptoms. Again, remember the first step in any of these endocrine disorders, similar to what we did for fluid and electrolytes, is learning which hormone we're talking about first and foremost. So diabetes insipidus has to do with antidiuretic hormone. It has to do with a deficiency of water conserving hormone or a decreased of water conserving hormone, decreased ADH. So again, with decreased water conserving hormone, we're not conserving, so that therefore we are urinating more, right? Polyuria is the major sign, 4 to 20 liters per day. So you can see death by dehydration. So all of the priority assessments are really related to hypovolemia and dehydration. So polyuria, of course, is going to result in the polydipsia. As soon as they get dehydrated, there's that thirst mechanism is going to kick in. Of course, the dry mucous membranes. If we think of our vital signs with somebody that's low on volume, blood pressure's low, heart rate is up as a compensatory mechanism. And then we talked about a narrowed pulse pressure. So that is going to be a decrease in the difference between the systolic and the diastolic. So the systolic and diastolic is normally 40, right? 120 over 80. So normal pulse pressure, as you remember, is 30 to 40. When that gap narrows and those numbers get closer together, in addition to the systolic blood pressure dropping also and the whole blood pressure dropping, that is called narrow pulse pressure. So we're watching for that as an early sign of decreased cardiac output. Weak, thready pulses, restlessness, may also see muscle pain and weakness. And then where this is coming from, the muscle pain and weakness, we want to be thinking of loss of electrolytes, in particular the chance of hypokalemia or that low potassium. So those safety things with loss of fluid and electrolytes, becoming dehydrated, dizziness, weakness, etc. Management of diabetes insipidus, certainly with all endocrine disorders, we need to identify and treat the cause. But one of the priority interventions for somebody who's hypovolemic, in this case hypovolemic from diabetes insipidus, is to replace fluid. So you're going to see that isotonic fluid flush, 0.9% sodium chloride. They may also order a hypotonic solution like 0.45 or 0.33. And again, what you want to remember here is that as they have fluid volume deficit, right, as they have low volume, they typically will have a concentrated hypernatremia. So they're going to have a low volume and a high sodium. So remember when we have that high sodium, that produces hypertonicity in the blood vessel. So basically it pulls fluid from the cells into the blood vessel, right? Fluid moves from hypotonic to hypertonic. So now we end up with the dehydrated little cells, and so that's why the hypotonic solution might be ordered, because now we have those dehydrated cells that we need to replace some water to. So again, draw your picture. I do the same thing so that you can keep it straight. Of course, we're going to encourage the drinking of fluids. We're going to do all of our I's and O's, daily weight, vital signs, all of the stuff that you have learned and that you know for fluid volume deficit. The only other thing that would be different that you haven't probably learned yet is the possibility of the hormone replacement. So vasopressin is the synthetic ADH. So depending on the cause of the diabetes insipidus, they may need to be on vasopressin for life. So SIADH, syndrome of inappropriate antidiuretic hormone. I once had a student say they remembered the I in the for the syndrome of inappropriate as increase. I mean, it doesn't stand for increase, but that's a great way to remember it, that there's an increase in antidiuretic hormone. So more water conserving hormone. So we know that this disorder has to do with retaining volume, excess volume. So fluid volume excess and hypervolemia. And then as we've talked about with any water imbalance, that's going to affect the sodium and vice versa. Sodium and water are always going together. So with the excess of volume of fluid, we're going to have a dilutional hyponatremia. Also could have dilutional hemoglobin, hematocrit, etc., as we've talked about. Your main signs and symptoms are going to be your signs and symptoms of either fluid volume excess, which those, again, I'm confident that you know. Blood pressure's up, heart rate's up, respiratory rate's up. They can have crackles in the lungs, jugular venous distension, increase in weight. So they're going to have fluid volume excess, definitely. And then they will likely have signs and symptoms of hyponatremia. So remember with the hyponatremia now, that is where the blood vessel is hypotonic. So it moves from hypotonic to hypertonic. So fluid moves out of the blood vessel and then goes into the cells. So it basically enlarges the cells and you end up with cellular swelling and cellular edema. So the signs and symptoms that you're seeing there with hyponatremia have a lot to do with that cellular edema and cellular swelling, the headache, the change in LOC, and those sorts of symptoms, seizures, coma, are all related to that change in cell size. So management of SIADH then, again, besides identifying and treating the cause, now we're looking at treatment of that fluid volume excess. They would be on a fluid restriction, 1,000 mils for 24 hours or 1,200 mils for 24 hours. Kind of depends on, how low that sodium level is as far as what sort of a fluid restriction they're going to have them on. 3% or 5% sodium chloride, which is a hypertonic solution. Now remember, we have cellular edema. So that hypertonic solution given in the blood vessel is going to pull fluid from the cell and interstitial space and move it back into the blood vessel. So we're going to get some of that fluid off of the cell. That's why they will order a hypertonic solution. Certainly they could prescribe loop diuretics such as furosemide for the fluid volume excess. And again, all of the other things that we know for any fluid imbalance, INO, daily weights, vitals. And then again, with the sodium imbalances, all of those neurological changes that can happen. So just remembering to keep the patient safe and protect them from injury. So this picture is just showing you that change in cell size that I know I've drawn on the boards. Again, I still draw this out as well to remind myself, which area is hypotonic versus hypertonic, to know how the cell size is changing. And then that really helps me to understand the fluid that's going to be prescribed for treatment. So it's definitely worth understanding it rather than trying to memorize it. So for these review questions, hopefully you've read them and ahead of time and answered them before you're listening, because I'm just going to give the answer and then if there's any explanation. So for this one, the correct answer is 4. I should limit my fluid intake to approximately 800 mils. So again, with an increase in ADH, there's fluid volume excess and that dilutional hyponatremia. So they are going to be on a fluid restriction to help with that. The answer for this one is 3, increased sense of thirst and increased urination. So, with that, we think of diabetes mellitus, or certainly could be diabetes insipidus. Those would be signs and symptoms for either of those. Of course, we'd have to know more details to understand which it might be. The correct answer here is 2. Didn't really talk too much about radioamino acid assay test, but with that, the antigen is added to the blood sample or after it's drawn, so there is never any radioactivity directly to the patient themselves. And for this one, of course, the correct answer is number 3, to urinate at the end of the 24 hours and add that to the collection container. So it's really important that we get that final void so that we have a full measurement of all of the urine that the kidneys have produced and whatever they've excreted in that urine, more importantly, that they're looking at for that full 24-hour period. So for this one, they're looking at that shows you that the treatment for diabetes is effective. One thing that I would do initially is say that with diabetes insipidus, there is decreased antidiuretic hormone initially. So I'm expecting initially with the disease, increased urine output and decreased specific gravity. So I do that first myself so that then I understand that if treatment is working, I would expect the opposite, right? If with the disease they have too much urine output and a low specific gravity, if they are getting fluids replaced and the things are working, then I would want a decreased urine output and an increased specific gravity. So the answer is 4. But you kind of have to think through this. You can see you can't just quickly look at the answers or you'll get yourself all mixed up. So hypopituitarism, we're not going to spend a lot of time here of this main disease, but this is also called Simmons disease. But while we learn all of the other disorders of the glands, you can hopefully understand that if somebody has a decreased amount of pituitary gland function, that affects all the glands. And as you saw in those initial pictures, that means that there would be a decrease in thyroid stimulating hormones, so your metabolism would be affected, decrease in growth hormone, decrease in antidiuretic hormone, decrease in adrenocorticotropic hormone, so steroids and things are affected by that, cortisol levels. So again, it's going to be a primary disease that's going to then have all of the signs and symptoms of the diseases that we're talking about individually. So that's why I'm not spending a lot of time, and you can just know that if they have if they have hypopituitarism or what we know as Simmons disease, that you would expect a decrease in all of those gland functions. The other thing to think about is that if somebody has a hypophysectomy, so if they actually remove the pituitary gland because of, like, say, a tumor or that's usually the most common reason why they have to do it, they will develop Simmons disease, right? If we take out the pituitary gland, they will have hypopituitarism. So that's also where you can apply this information. I will let you just review this slide, and I know things are small, but it does just kind of make the connections of each gland. If we have pituitary gland dysfunction, what sorts of signs and symptoms are going to clump into the thyroid area, the adrenal glands? Again, the most important things. If you look at the adrenal gland, for example, low blood sugar and low blood pressure, those are the most critical signs and symptoms if we don't have enough hormone being produced from that gland. So the more we look at this, the more we kind of learn the associated signs and symptoms and priorities, the easier it is to answer questions about them and to better understand the diseases themselves. With hyperpituitarism, then, we're going to have just an excess in all of the various pituitary gland functions. Again, all of the organs that are being activated by the pituitary gland, the thyroid, the steroids, and all of that. So again, you can see a lot of the changes. They have increased growth hormones, so they have those enlarged feet, hands, maybe very, very tall. They can have that oily, rough skin because they actually have, or deep voice, acne because they have excess androgens and excess testosterone. And again, they have hyperglycemia because of the excess in cortisol hormone. So a lot of again, if you know all the other glands, it makes it a lot easier to understand what it would look like if we have excess of all gland action or production of those glands affected by the pituitary. So hyperpituitarism is also known as acromegaly. So this picture again shows the signs and symptoms. Again, some of the key signs and symptoms by body system. My brain learns the lot really well this way when I can see it broken down by kind of body part or body area. So you can see how those different glands, excess glandular function will affect the different body systems.